started. So the session for this afternoon, which is in between lunch, I don't know whether it's post-lunch or interim in the lunch, it's going to be on mastering uveitis care, which is about essential do's and don'ts. So the speakers for this session will be focusing on some of the pearls in standard management of uveitis, which will be helpful not just for the uveitis specialist, but also for general ophthalmologist as well. We expect the speaker to stick onto the time, and then we'll also entertain one or two queries from the audience, just to on the same topic and not keeping at the very end. So with that, I'd like to introduce my co-chairs, Professor Jyotirmay Biswas, who does not need any introduction in the field of uveitis and is from Shankar Nethralaya, and Professor Harvey Hui from Manila, Philippines, once again one of the leading figure of uveitis in Philippines. So we will be moderating the session together. With that, we get started, and I want to kind of ask Dr. Harvey Hui to introduce the first speaker and invite.
Yeah, it's my great pleasure to introduce Dr. Zeng Xiang Thing from Singapore to talk about early diagnosis and intervention.
So Zeng Xiang is a young uveitis consultant from Tan Tock Seng Hospital, Singapore, and he did his fellowship with none other than Professor Kwan Dong Wen, and recently, and he is one of these real experts in looking beyond what a regular uveitis specialist see, and therefore he will come up with early diagnosis intervention. Zeng Xiang, over to you.
Thank you for the kind introduction, ladies and gentlemen. Good afternoon to all. So my topic is early diagnosis and intervention in uveitis patients, and in the next 10 minutes, I hope I can share with you some pearls that I have found useful in my own practice. So I have no financial disclosures. So the first question is, why do we need early diagnosis and intervention? So we do know that certain forms of uveitis are rapidly progressive and sight-threatening, while others have systemic implications and may be life-threatening. And of course, we do know that repeated flares of ocular inflammation usually gives us a poorer outcome. So let me share some of the pearls that I've learned. The first one needs no introduction, right? Always rule out infectious etiologies. But to that, I would like to add a second part, which is not all infections are equal, and we really need to be careful of the very virulent ones. So here on the slide, you see on the left some common microorganisms that affect the eye, and I guess in this part of the world, everyone will get tested for TB and syphilis. But really bear in mind endogenous endophthalmitis and also the concept of co-infections. And in this paper from South America, looking at a cohort of ocular toxoplasmosis, about 7.5% of patients actually have a dual infection. Now let's jump straight into a case. So we have an elderly Chinese male with non-infectious uveitis, suitably immunosuppressed systemically as well as on drops. And you can look at the anterior segment photos as well as the posterior segment photos, which are unremarkable except for glaucomatous discs. Now he walks in 1.5 years ago with blurring of vision and visual field defects. You can see here widespread vascular occlusion and a suspicious area of retinal whitening superiorly at 12 o'clock. Now you do the angiogram, massive capillary fallout. So you put two things together, immunosuppressed patient, retinitis, occlusive vasculitis, straight away you should go for an AC tap to rule out viral retinitis. The attending physician did so and treated the patient appropriately, systemically as well as intravitreally, and the patient was doing well for 2 weeks. Now things start to change again. So the patient now has worsening of vision and discomfort. The eye looks angry, injected, you see some fibrin. Look into the back, vitreous haze of 3 to 4 plus. This can no longer be viral retinitis, so stop kidding yourself. It is either exogenous endophthalmitis or concomitant endogenous endophthalmitis. Diagnostic vitrectomy, capsular was done, capsular was grew and treated intravitreal with vancomycin and ceftazidime. But even with the fastest and earliest of interventions, this patient eventually had panophthalmitis and enucleation within 3 weeks. So this just drives home the point that despite sometimes our best efforts at early diagnosis and intervention, we might still lose the battle. Let's switch a little bit of gears to the autoimmune conditions and the eye. For this group of patients, I do want to recommend to examine the patient systemically, carefully, and then tailor a serological workup. Let me tell you what I mean. So this is a patient, do I have the marker here? So this is a patient I saw with only 2 episodes of anterior uveitis at 41 years old of age. But I found that he had problems coming to the slit lamp. And if you can notice, he had extremely limited range of motion in his neck. So straight away you think of the common phenotypes and the common autoimmune diseases. B27 uveitis would be right at the top. Ankylosing spondylitis, to be exact. So we do know from literature that half to 3/4 of the patients with B27 positive AU will have a concomitant spondyloarthropathy. And more than 50% of patients will have their diagnosis made by the ophthalmologist. And lastly, we do know that B27 AU does have a poorer prognosis than idiopathic AU. So we should really try to avoid such debilitating morbidity, especially in young patients. I'll show you a second patient just to drive home the point. So this is a 52-year-old female coming in for a second opinion for scleritis. She looks pretty well controlled, right? With peripheral scarring of the cornea, but essentially a really white eye. If you think about the common causes of scleritis, rheumatoid arthritis, granulomatous with polyangiitis, relapsing polychondritis. Now examine the patient systemically. You see a saddle nose deformity, and you see effacement of the helix of the external ear. The diagnosis of relapsing polychondritis is almost made even without a biopsy. But you might ask, why is this important? Because certain rheumatological disease does confer an increased risk of mortality. GPA, for instance, have a risk of mortality of up to 40% if the kidneys are involved. And all these can be reversed with early diagnosis and early intervention. Coming to the masquerade syndromes, let's talk a little bit about the non-neoplastic portion of it, and I would like to highlight UGH, uveitis glaucoma hyphema syndrome. I always tell myself to be suspicious of a patient who has an intraocular lens and a new onset of uveitis post-cataract surgery. Of course, it may well be idiopathic. It may be a retained lens fragment that you can see on the photo on the left. That's a large one. That's easy to diagnose, but more subtle ones may need gonioscopy. We also mentioned about ruling out infections, so chronic endophthalmitis must always be on the list. But lastly, UGH is not so easy to diagnose. It's rare, it's about 1%, and it can happen in all sorts of lens implants, not just the ACIOL or the sulcus lens. And the problem is it has a median time of onset within years from the initial cataract surgery. So I have this patient who had phaco trap surgery 15 years ago, now presenting with hypertensive uveitis, 2 separate episodes over 6 months. It was only on retro illumination I saw a nasal curvy linear odd-shaped iris atrophy. Now I went forward with a UBM, and you can see in the rectangular red box the sulcus placement of one of the haptics. Another case to drive home the point, this patient has bilateral cataract surgeries done. The right eye is fine. In the right eye, I'm trying to show that there's an appropriate sulcus space between the iris plane as well as the lens back complex. In the left eye, he has been suffering from what people have labeled as uveitis and microscopic hyphema for the past 6 months. If you look at it, the sulcus space has been obliterated, and the dotted line showed an extremely distended capsular bag. So this patient actually has an extreme form of capsular block syndrome with concomitant UGH due to the anterior displacement of the lens back complex. This was easily solved with a YAG laser. So in summary, I think you can look and dilate the patient fully to see the CCC rim. You can try to check for IOL stability, look at the sulcus space, consider gonioscopy and UBM as well. As we come to the last part, I think this is always important to remember. Life-threatening conditions where we would not want to miss, and intraocular lymphoma must be one of them. So here we are talking about vitreoretinal lymphoma, and we should always be suspicious of a patient who presents with new onset and floaters and vitreous haze when they are older than 50 years old. The vitreous haze could be non-specific as shown in the photo on the left, or it can be an aurora borealis pattern reported 40 to 60% in some case series. So I have a patient who exactly has that pattern. These are linear opacities and sheets of cells that are arranged radially from periphery to central. And surprisingly, they usually have little cystoid macular edema because it's vitreous infiltration and not vitreous inflammation, and they usually have good vision. If it is more advanced, obviously you see the subretinal or sub-RP yellowish infiltrates. OCT biomarkers as well as B-scan biomarkers have been also described. Why is it important to not miss this diagnosis? Because we know 50 to 90% of patients will develop primary CNS lymphomas between 1 to 2 years, which is invariably fatal if untreated. So in summary, I would like to urge you to rule out infections. Remember, not all infections are equal. Recognize common autoimmune diseases and their ocular phenotype. And lastly, always think of UGH and intraocular lymphoma. I thank you for your attention.
So the paper is open for discussion. Any comment, any inputs, any question for our expert speaker? So if no question means everyone is very confident about the early diagnosis and management of uveitis, looks like.
It means I have an easier time after lunch.
Yeah. Means like, yeah, please.
Yeah. Yes, please, Dr. Harvey.
So now it's becoming more common to place these iris fixated lenses. Are you seeing patients with uveitis after placement of these lenses?
So I don't think I've seen many iris fixated lenses. The type that I've seen are mainly the claw lenses. Yeah. And in general, I think what we worry more is the subluxation of the claw lenses rather than UGH. But of course, they may not be the best choice of lenses in a patient with pre-existing uveitis. My colleagues tend to go with a SFIOL, a scleral fixed lens, if the patient has pre-existing uveitis.
In vitreoretinal lymphoma, have you seen that cases with intermediate uveitis and presenting as intermediate uveitis and develop later on vitreoretinal lymphoma?
Actually, I think that's one of the most common presentations. It's usually intermediate uveitis. It's usually intermediate uveitis in an elderly patient. When I say intermediate uveitis, from the cases and my experience that I have, it's usually more asymmetrical. It may be bilateral, rarely though. It usually starts unilaterally. But that's one of the main diagnoses that I have whenever a patient of an elderly age comes with intermediate uveitis. We do know that from literature, it's always a diagnostic journey for patients with intraocular lymphoma because the gold standard of diagnosis is still a biopsy. I would say, I'll put to you that imaging has helped us come some ways. OCT findings, especially outer retina changes, are always useful. Autofluorescence, and don't forget, you don't really have to jump straight into a diagnostic vitrectomy. I'll leave this to the ocular oncologist to debate, but there are other options when it comes to a biopsy. So you can do an anterior chamber tap, you can do a vitreous tap as well, and do consider things like MYD88 or MYD88 mutation to try and be less invasive if you can in your patients. And also, if you do an MRI and you see the brain, then you pass it on to the neurosurgeon to do the biopsy. So that solves your problem.
Thank you very much. We call upon now Dr. Wataru Matsumiya from Japan. He will be talking on comprehensive multimodal imaging. Dr. Matsumiya.
Thank you so much. Hello, everyone. And I appreciate the kind invitation to participate in this meeting. So my talk is a comprehensive multimodal imaging. Here is an example of the application of the multimodal imaging to the multiple evanescent white dot syndrome. Fundus portal, fluorescein angiography, and indocial green angiography, fundus autofluorescein OCT, and multifocal ERG are combined to evaluate and monitor the disease. So here's a table showing the pros and cons in each imaging modality. The advantage are the following. The closest appearance to a view via the ophthalmoscopy and on fundus portal, and enable evaluation of the neovascularization and non-perfusion leakage, and showing the hemodynamics on dye-based angiography. Assessment of the RBP function on FAF, and high resolution close to the pathological section image on OCT, and visualization of the vasculature without any invasion on the OCT angiography. So today I will show some representative case and assessed with multimodal imaging. First case is HLA-B27 associated uveitis. So fundus photo OCT, FA were applied to this case. So here is a case of the 35-year-old female with HLA-B27 associated uveitis. Her left eye showed anterior uveitis that's accompanied with the hypopyon in the anterior chamber. At that time, her vision was 20/80. The fundus photo looks non-remarkable. However, the OCT showed multiple hyperreflective dots and the vitreous on the OCT, so suggesting the posterior inflammation. So actually, FA was performed in this case that it showed a leakage from the optic disc and the retinal vasculature, confirming the presence of the posterior inflammation. So posterior inflammation in HLA-B27 associated uveitis is not rare. According to the report from my colleague at Stanford University, about 50% of the HLA-B27 positive patient presented with a posterior segment involvement. So careful assessment into the posterior segment should be considered even in the anterior uveitis. On another aspect, so hyperreflective vitreous cell on OCT has been proposed to be a biomarker of the posterior inflammation. So OCT may help not to miss the posterior inflammation. So next case is white dot syndrome. So all imaging modality were applied to this case. So here is a case of the 10-year-old girl with a bilateral panuveitis. The left eye is highlighted here. Her vision was 0.4 at that time, and fundus photo showed multiple subretinal yellowish white lesions. 1 week later, the fundus photo showed whitish lesion with a well-defined margin. OCT showed some scattered the hyperreflective dots in the vitreous, and the diffuse disruption of the ellipsoid zone. FA showed hyperautofluorescing spots and late staining. ICGA showed the hypocyanous spots. On the FA, FAF showed a mixed pattern of the hyper and the hypo patches. The OCTA image of the choriocapillaris and showed choroidal hypoperfusion corresponding with the white region. So she was diagnosed with acute posterior multifocal placoid pigment epsilopathy, AMP, based on the imaging findings and the clinical course. Actually, she was treated with systemic steroid. At 6 months, her vision improved to the 1.0, and white region has changed to the atrophic region. OCT actually showed improvement, although there is a small amount of the disruption of the ellipsoid zone. On FAF, so the lesion, hypoautofluorescing lesion got smaller. So choroidal hypoperfusion on OCTA has improved. So here is a table showing the characteristic between the different imaging between the AMP and versus Muse. Actually, AMP and Muse have similar findings in imaging. However, multimodal imaging and OCTA indicate inflammation and hyperperfusion at the level of the choriocapillaris. And while Mills is indicated to be a disease of the outer retina and RPE. So multimodal imaging should be considered to differentiate white dot syndrome. So next case is a disease mimicking white dot syndrome or azole complex. Fundus photo, OCT, FA, and ICGA were applied as well. Here is the case of the 37-year-old male. His right eye showed a whitish oval region at the posterior pole, but the left eye showed unremarkable. OCT in the right eye showed a disruption of the ellipsoid zone and absence of the interdigitation zone, as well as hyperrefractive dots in the choroid. OCT in the left eye also showed a disruption of the ellipsoid zone around the disc. So those findings are compatible to the white dot syndrome or the azole complex. However, fundus FA fluorescein angiography showed a leakage from the optic disc in the both sides and retinal vasculature in the right eye. ICGA showed multiple hyperpatches in the mainly right eye, and FAF showed hyper autofluorescein in both sides. Actually, he was diagnosed with ocular syphilis based on the positive result of the blood exam and cerebrospinal fluid test. Acute syphilitic posterior placoid chorioretinitis, SPPC, is characterized by the development of the placoid macular deposit in the outer retina. It is a rare, relatively rare, the ocular manifestation of the syphilis. However, we need to consider the possibility of the ASPPC when we see the case of the white dot or azole complex. So here's the clinical parts. The multi-directional imaging approach with a different modality can improve the disease diagnostic and therapeutic management. Multimodal imaging should be applied to even the anterior uveitis, not to miss the presence of the posterior inflammation. So multimodal imaging will help to differentiate white dot syndrome, and infection such as the syphilis must be ruled out before generating the diagnosis of the white dot syndrome or azole complex. Thank you so much, and we will welcome to join AIOIS2025 in Rio. Thank you so much.
Thank you. Amazing, very good talk. Any comments, inputs, anything? Yeah, please. You can come to the mic and speak out about any comments.
Hey, this is Dev Shah from Kathmandu.
Yeah, can just close to the mic.
As far as HLA-B27 related uveitis, I think multimodal imaging, this is my perception, in every case in developing countries probably will not be possible, sheerly because of the cost. Secondly, it is known since long time, unlike human beings, sometimes we don't care even about our neighbors, our organs and the other things in nature. They are always very sympathetic to each other. So if the anterior part is involved, to some extent posterior part will also be involved, and so also vice versa. And the clinical evidence of that is amply available, that in anterior uveitis in plenty of cases we see cystoid macular edema, which is the involvement of the posterior part. Okay, and one of my professors, Professor Jain, Dr. Biswas, he used to tell that uveitis seldom is in isolation. It is mainly one part is more involved than the others, and that also we see in the HLA-B related, HLA-B27 related uveitis. So to increase our knowledge, pathophysiology is fine, that for research purpose we can go ahead in every case with multimodal imaging. But practically in developing countries, I think once you have HLA-B27 positive, we mainly see the picture of anterior uveitis. It is practical to be going ahead with the usual treatment of anterior uveitis. I think so.
Thank you so much for your comment. And actually, I totally agree with you that actually, you know, the multimodal imaging is a very ideal the strategy for the to evaluate the uveitis. So so depending on the situation, and we need to consider the strategy. Thank you.
In view of time, we probably have to move on. But if time remains at the end, panel discussion, so we'll take your question at the end. But point well taken. And thank you very much for your wonderful talk. And we move on with the next talk. Thank you so much.
Thank you.
So with that, I'd like to invite my dear friend, Dr. Padma Malini Mahendra Das from Bangalore, Narayan Netralaya, for her talk on uveitic macular. Is that uveitic macular edema, Dr. Padma? No. So it's optimal use of steroids in non-infectious uveitis. So I think uveitic macular edema is for another talk, because that will come afterwards, the management and the things, so complication. Okay, while maybe you want to come up and then ask your question while we are setting up the correct talk.
The previous presenter from Japan. So I would like to ask if you see the vitreous involvement in case of HLA-B27 with the help of multimodal imaging,
so
would you consider different treatment if you see a little bit of vitreous involvement? Would you consider some change in the treatment? Would it help you in planning different treatment than previously what you thought?
So on your imaging, if you see vitreous inflammation, let's say on OCT, if you see vitreous dots, is it going to change? Is it going to change your treatment based on your imaging? That's what she is trying to ask.
Yeah, actually, and you know that macular edema, the posterior inflammation of the posterior segment may affect the visual acuity. So we notice the posterior inflammation, we may decide a more aggressive therapy in that
like
case.
Like oral steroid or intravitreal injections of steroid.
Yeah, depends on the
even if vision is just slightly, involved.
So I think it will depend on case to case. So just as a take-home message for everyone, the imaging modalities are there to help you, guide you, but cannot be the sole thing in the decision making. So you have to kind of take into the entire consideration, the entire picture, and based on symptoms, the visual acuity and many things, probably to take a call. Yes, Professor Kwan, just a last comment quickly, because I can't say you know.
I think the last point is important. As we say, one image would not make a difference. Whether you see the first time you see the fluorescein angiography with leakage, we are not proposing that we treat. When we did the study to show how HLA-B27 associated uveitis can explore the posterior segment, the goal that you point out, if you were to see progression, let's say the first time you see an FA, you see some involved, 3 months later you see more and more involved, then you definitely now have to think of that and look at what the functional is of that patient. What will the ERG show? What will the Goldman visual field show that? Then you say, okay, perhaps at this moment, we need more aggressive. Not corticosteroid, we have to go past corticosteroid stage. At that time, we have to use steroid-sparing agent. One image would not make a difference, but if you were to see gradual progression disease, then yes, at what I would say, that would be very helpful. Thank you.
Thank you. Good. So let's move on with the topic of optimal use of steroids in non-infectious uveitis by Dr. Padma Malini. Yeah.
Thank you. Very good afternoon to all of you. Come to the talk on optical use of steroids in non-infectious uveitis. I do not have any financial disclosures. Corticosteroids have been the mainstay of treatment for non-infectious uveitis for the immunosuppressive effect. It's act by inhibiting production of the pro-inflammatory mediators such as cytokines and chemokines, thereby suppressing the immune cell activation and proliferation. They thought to be act by induction of phospholipase 2 inhibitory proteins called lipocartins. The administration of corticosteroids, the route and the dose depends upon the age of the patient, immune system of the individual, severity of the inflammation, the location of the uveitis, the duration of the disease, presence of any ocular or systemic comorbidities, tolerance and adverse effects of prior history of corticosteroids, and response to treatment. Based on these effects, we'll choose the drug and the route of administration. Coming to the route of administration, commonly for anterior uveitis, the topical corticosteroids are used. Ointments are also available. Subconjunctival or periocular steroid injection is useful to treat the inflammation either in the intermediate or in the posterior. Intravitreal injections and corticosteroid implants are also available. Iontophoresis using the dexamethasone have been used in the clinical trials to control the inflammation. Suprachoroidal route is of triamcinolone acetonide injection helps to control the inflammation of the posterior segment. Coming to the corticosteroids used in uveitis, we based on depending upon the activity. Commonly used ones are intermediate acting one prednisolone. Long acting dexamethasone and betamethasone are also used to control the inflammation. Coming to the topical steroids, the dexamethasone and prednisolone are the commonly used drug. They have good penetration into the anterior segment to control the inflammation. If the patient is a steroid responder, the low potent steroids like loteprednol can be used. We'll see the case examples. Here, the 52-year male present with acute anterior uveitis, HLA-B27 associated disease, where we have anterior segment reaction with traces of hypopion. And this particular patient treated with topical steroids, cycloplegics and systemic NSAID responded well in 6 weeks' time. We did not have any associated systemic activity. The next case is a 52-year recurrent anterior uveitis, where we can see the medium and mutton-fat keratic precipitates. This particular patient had cystoid macular edema in the posterior segment of the eye. Investigations, the common diseases like TB, sarcoid and other causes have been ruled out. We've used a topical difluroprednate which has penetrated into the posterior segment of the eye, like vitreous cavity in the posterior segment, resulted in controlling the inflammation and disappearance of the macular edema. The next case is a 22-year female unilateral non-granulomatous anterior uveitis with vitritis. It again HLA-B27 related. At presentation had posterior synechia with fibrinous anterior segment reaction. This particular patient was started on topical steroids, cycloplegics, and also we have started the patient on oral steroid because of the structural changes. 5th day follow-up, we could see there is a disappearance of the fibrinous reaction and broken posterior synechia in the anterior segment. We started this patient on methotrexate and stepped up the dose. We could see the resolving inflammation. However, the patient showed recurrence on 5th month follow-up with methotrexate. Because of associated systemic activity, we initiated the patient on biologics. With this, the patient is doing well. So depending upon the etiology and the severity, we choose the drug administered. Next, we will move on to posterior subtenon's injection. This periocular could be given in the form of transeptal or subtenons. They are least invasive than intravitreal injection. Usually used to control intermediate uveitis and the macular edema. Since it is a blind procedure, it has its own complications like low perforation, can have proptosis, or repeated injections can cause fibrosis of extraocular muscles with anophthalmos. Especially young individuals, when we are giving, we have to be careful because they can cause mild ptosis, can have arterial occlusions, optic nerve injury. Commonest complications to any other route of steroids include cataract formations and increase in intraocular pressure. According to the result from the POINT trial, both intravitreal triamcinolone acetonide and dexamethasone implant are superior to periocular triamcinolone acetonide for the treatment of uveitic macular edema with modestly greater rate of increase in intraocular pressure. Intravitreal steroid injections, both dexamethasone as well as triamcinolone, can be given to control the inflammation. Here is a patient with macular edema treated with IVTA, showed resolution of the macular edema. Coming to the intravitreal steroid implants, we have fluocinolone acetonide reticet or dexamethasone Osidex implant. They have predetermined dose, fixed delivery over a period of time. They can be placed into the vitreous cavity, and this acts for many months. Let's move on to the case example. Here is a case of Osidex which is used in bilateral retinal vasculitis. A 48-year female presented with history of diminution of vision. She also had diabetes mellitus, complaining of wavy lines. She had early lens changes and vitritis was present associated with anterior segment reaction in the left eye. Fundus examination, the media was grade 1 haze and there was mild cystoid macular edema was present. The greatly attenuated arterioles were seen. Blood investigations were all normal. The patient was started on oral steroids with closely monitoring. However, the CMV was not disappearing. 1 month follow-up, we could see the presence of cystoid macular edema, gross arteriolar attenuation and few pigmentary changes in the periphery. So this is following within 1 month. You could see the resolution of the macular edema following Osidex injection. At 3 months, there was deposits and pigmentary changes were seen. This is in the other eye where you could see the resolution of the macular edema following Osidex. We could see the presence of Osidex in both eyes, which helped to control the inflammations and disappearance of macular edema in this patient. Cases with non-dissolving CMV or vitritis, even with oral steroids or immunosuppressives, Osidex can help to control the inflammation. Next is a case of autoimmune uveitis. A 41-year female presented with blurring of vision, underwent Parthena vitrectomy with allied procedures in 2021. She had anterior segment reaction in the form of congestions and nodules, conjunctival nodule in the right eye. There was BSK and medium-sized keratic precipitates in the right eye. She had a chronic inflammation where we could see the pseudophakia in the eye with the macular edema and significant vitreous haze. This particular patient, Osidex was given since it was unilateral and the patient responded well with reduction in the macular edema. Coming to the literature review, Urian trial evaluated the efficacy of 2 doses of dexamethasone implant in non-infectious intermediate and posterior uveitis. This is a bar graph showing the results. Another study by Dr. Biswas and group have done the retrospective study of patients with intermediate uveitis with macular edema with vitritis were refractory to the treatment but subsequently treated with Osidex, and they shown promising results. This is a case example where non-refractory resulted in resolution of the macular edema. Suprachoroidal administration provides precise access to the suprachoroidal space to the back of the eye, results in controlling the inflammations and also resolution of the macular edema in non-infectious posterior uveitis. Orals, when the local therapy is not effective or if you have a bilateral severe disease, we start the patient on oral steroids, prednisolone 1 mg per kg body weight with a tapering schedule. So this is the thing, we start with 1 mg and then gradual tapering. If it's over 40, we taper 10 mg per week. If it's 40 to 20, 5 mg every week, 20 to 10, decrease by 2.5 mg every 1 to 2 weeks, and 10 mg is lesser dose. We follow the Gordon's dictum, use enough, soon enough taper and discontinue the corticosteroids. We monitor the blood sugar and BP, and we have to supplement it with calcium supplements. Deflazacort is a newer drug which is useful, especially if the patient is a diabetic. In severe cases, we give intravenous methylprednisolone 1 gram per day for 3 days followed by oral steroids. Diseases like VKH, it's a multi-system autoimmune disease. Female are commonly involved. Anterior segment can have mutton fat KPs, shallow anterior chamber with iris nodules. Posterior segment, we can have disc edema in acute and Dahlen-Fuchs nodules in chronic cases with sunset glow fundus. When they present with acute exudative detachment, we treat them with IV methylprednisolone, following which there is resolution of the exudative detachment in these cases. Yes, steroids as contraindications, we try to avoid patients of associated ocular infections, or if you are giving under cover of appropriate antimicrobial therapy, it has to be given. History of steroid-induced glaucoma or uncontrolled IOP, corneal thinning or perforation, it can hypersensitive reaction in some individuals, uncontrolled diabetes, gastrointestinal ulcers, osteoporotic cases. In pediatric individuals, we have to be careful when we are giving systemic steroids. Here is a case of a 73-year-old lady, pan-uveitis, probably secondary to sarcoidosis. She presented during the pandemic. She was given difluroprodnate with methotrexate. She stopped the methotrexate due to non-availability and she lost for follow-up and she continued to use the difluroprednate, resulted in glaucomatous optic atrophy, the loss of vision in the right eye. This is a flow chart showing the management evidence of anterior segment inflammations. We use them with topical steroids. If the posterior segment inflammations, we exclude latent infections, treat them with systemic steroids. If they are poor response, we switch over to immunosuppressive drugs or biologics. Coming to corticosteroids, we choose the correct method of corticosteroid therapy depends upon the type of the uveitis. We need to titrate the dose not only for the eye and also for treat the associated systemic symptoms. We should not give inappropriate method or the route. We have to give adequate dosage, and failure to recognize associated complications like CSCR can result in worse outcome. Corticosteroids are the cornerstone for non-infectious uveitis treatment. Their administration requires careful consideration depending upon the clinical situations and specific type of uveitis. These are my acknowledgements. Thank you for your attention.
Nowadays, that recent time that FDA has approved 0.18 milligram of fluorouracil, a steroid implant intravitreally, and can you tell the role of that intravitreal fluorouracil implant in uveitic macular edema?
Is a long-acting one, but that has its own complications like steroid-induced glaucoma and the cataract are more compared to the dexamethasone implant.
Thank you, Professor Mahendradas, for that very nice talk. We'd like to move on now to our next speaker. And it's my pleasure to introduce Dr. Annalisa Ko from the Philippines. She did her fellowship at the Sydney Eye Hospital and is now practicing north of Manila, and she'll be speaking on monitoring and follow-up strategies in infectious uveitis.
So I do know there are some raised hands at the back, but in view of time, we are moving forward. So we are taking 1 or 2 questions at the max, and there was no time therefore, but you keep your questions, and if time permits at the end for panel discussion, we'll come back to you. Or in between, there will be some technical lag, and that time we'll get you to ask your question. So be ready with your question. Thank you. Padma, you have 1 question to answer for a person in the behind, but later on, not now. Okay. Dr. Annalisa? Again, incorrect talk? Is that not the correct?
Yeah, there's just a little bit.
Okay, you got a chance. Can speak. Yeah, we use the time. Yeah, please come to the mic and speak about what you want to ask.
Oh, okay, she's good.
Now, okay. Never mind, he's getting up.
Okay, one question, then we'll start the talk.
Ready?
Ma'am, I just want to ask, if a patient has uveitis, and of course you have done a uveitic profile, HLA-B27, ANA, whatever autoimmune markers are positive, so usually treatment course follows like this. We do topical steroids, and the patient has CME or something, we give oral steroids, and if it's a resistant case, you go for IVTA, Ozurdex, and if it's still resistant, usually some surgeons also prefer to go for PPV later on also. So my question is, where does exactly biologics fit in this paradigm of treatment? When should an ophthalmologist consider to start the biologics? And secondly, what are, in your clinical practice, what are your results compared to other therapies, and the cost effectiveness of the treatment compared to the other options that we have on the market?
So, wait a minute, Dr. Padma, because that one will be answered by Dr. Pei-Jing Yang in his talk, and we wanted to keep it restricted to the use of topical steroids in infectious uveitis. So, we'll go for that. And I know this is a good question, but this itself is a complete lecture by itself. So, we can't take it up. It was a script's answer. So, uveitis gives you a very small window of opportunity. We got that, but we go back to our thing. Okay.
Okay, Ken. Go ahead, Annalisa.
So again, good afternoon, everyone. I'm Dr. Annalisa Ko, and again, thank you for inviting me and giving me an opportunity to talk on monitoring and follow-up strategies for infectious uveitis. I have no financial disclosures. So this is the outline of my topic. So for this talk, monitoring matters. So not just for uveitis specialists, but also for general ophthalmologists and trainees. And especially that after a tedious uveitis history, ocular exam, and investigations, we must know what we should expect in the following visits. So infectious uveitis can comprise 10 to 25% of cases seen in public uveitis clinics, and effective monitoring is very critical in allowing us to promptly adjust the treatment and ensure that we get optimal or great visual outcome. So let's break it down to 3 key principles. So first is establishing the monitoring framework. So this involves, again, getting a good detailed history, ocular exam, and investigations, since this will be the basis of our comparison for future visits. Identifying the red flags, because being able to spot this, the warning signs, the signs and symptoms, and even cases of issues in terms of adherence, in terms of treatment, should be noted, and that could actually make us adjust the treatment and adjust the follow-ups accordingly. So now we'll proceed with the common infectious uveitis conditions, and there's so much to mention for each of them, but we will focus more on the important ones to monitor. So first would be the viral anterior uveitis. So the challenge here is the chronicity and recurrence of it. So besides the IOP spikes, sometimes we would encounter issues in terms of resistance to treatment, and in these cases, further evaluation, including a possibility of doing further investigations like PCR, and also taking into account that probably we missed something and we need to recheck the status of the fundus, could probably help us in doing, in guiding us in our next step in treating these patients who present with resistance to treatment. So another issue in these cases of viral anterior uveitis is when the time comes that they need to undergo cataract surgery. So in a study by Liu and colleagues, they had 40.4% of their patients had recurrences after phacoemulsification in this type of patients, and the risk was seen that among patients with a higher number of recurrences before the surgery, as well as a shorter time of interval from the last flare to the cataract surgery, and most of them occurring within the first 2 years. And this type of patients should be highly encouraged, or should be given prophylaxis prior to the surgery and even afterwards. So another would be acute retinal necrosis. So what should we watch out for this? So primarily, acute retinal necrosis has this rapidly progressive retinitis, and because of this, very close monitoring is very essential. And once the inflammation subsides, the next problem would be the risk for retinal detachment. Besides this, other things that we need to monitor is preventing the involvement of the other eye. And besides this, we should also check for any signs of reactivation once they're quiet, and also monitor them for adverse effect of antivirals, especially for elderly patients and those with CKD or chronic kidney disease. So for CMV retinitis, I just want to emphasize that they have a higher retinal detachment risk as well. But in the era of antiretroviral therapy, this proves that it gives a decreased viral load and an increase in the CD4 count, thereby causing reduction in terms of CMV reactivations, especially when the CD4 count is more than 200. And it allows us a possible discontinuation of anti-CMV therapy in cases of non-sight-threatening cases. So next would be the monitoring in syphilis. So usually they are started with IV penicillin G. And while on this treatment, they may occur, paradoxical worsening may occur, of which steroids is used to avoid this phenomenon in coordination with the infectious disease. It's also important to treat the partner as they may be the source of reinfection, especially seen in MSM groups. And it's important to monitor treatment effectivity with titers with the goal of a non-reactive or long-term low titer to ensure treatment effectivity. In terms of ocular TB, patients who have this will be started in anti-tubercular therapy, and improvement is usually seen within the first 2 weeks to 3 months. And if there's no response noted within this time frame, a second-line agent may be beneficial in coordination with the pulmonology or infectious disease. It's also important to note, once they are started in this medication, that those who receive the treatment as long as 9 months, their recurrence rate are a lot less. And then when it's combined with steroids, the recurrence drops to 6.8% only. So next would be the infamous endophthalmitis. So studies emphasize that frequent assessment is important within the first 48 to 72 hours, especially after intravitreal injection. So we could detect early the treatment failure, if there is treatment failure or progression earlier. And we could advise further management like a second dose of intravitreal injection or vitrectomy if this was not done in the during initial treatment. Also, if there's no view of the fundus, it would be helpful if we have serial ultrasound imaging, so that could guide us in terms of treatment intervention. And it's really important to request for AIOIS and to send samples for testing, because it not only gives us a definitive diagnosis, but it also guides our targeted therapy in terms of encountering cases of antibiotic resistance. Also, you have to take note that in patient, the secondary complications includes the following, especially the retinal detachment. And in patients who had a culture positive result, they tend to have a higher risk for retinal detachment, since this indicates a higher pathogen load as well as thereby causing a worse outcomes. Just want to emphasize in regards to fungal endophthalmitis that monitoring the chorioretinal lesions and its seeding into the vitreous is very important, as well as vitritis that's very persistent even when the chorioretinal lesions are already regressing. These conditions might imply or might indicate for us the need to escalate care and giving parsplina doing vitrectomy or giving serial intravitreal injections. And lastly, toxoplasmosis in immunocompetent patients. It's often self-limiting, but the recurrence is a real threat in toxoplasmosis. And in the study by Bosch, Driesen, and colleagues, they reported an alarming reactivation rate as high as 64%, and down to 14.3% by the third year. So this emphasizes the need for prophylaxis, especially if the lesions are visually threatening. So with that, knowing the factors, we will go over the essential do's and don'ts. So the do's are our foundation. So do ask for subjective changes since the last visit. Do regular assessment and consistent assessment of the vision, the pressure, and inflammatory activity. Do adjusted therapy based on treatment response, check for treatment adherence, and do perform necessary imaging to detect subclinical changes. And then for the don'ts, which are the common pitfalls, first would be do not overuse the steroids, especially, for example, in cases of intravitreal steroids, in immunocompromised patients that can reactivate CMV retinitis. Do not miss systemic use in atypical cases. Do not delay treatment, especially in cases of endophthalmitis. Don't hesitate to offer vitrectomy or surgical management. Do not underestimate recurrence risk. So let me share with you a case of a 77-year-old male who presented with a 5-day history of blurred vision, presenting with a unifocal chorioretinitis with severe vitritis. He was recommended to do a tap and inject, for which he initially refused and opted to have topical medications and basic systemic investigations. And a day after, the lab results came back negative, including toxoplasma. Then history was revisited, and a recent dental infection 3 weeks prior was noted, and antibiotics was given, for which he self-ceased due to nausea. At this time, he already agreed with the tap and inject. He was given medications coordinated with infectious disease, and specimens were sent for investigation. Day 10, their investigations were negative. There was no improvement. Vitrectomy was offered, but he still refused at this time. At this point, he was started on oral steroids in the hopes of controlling the inflammation. Day 20, there were new lesions, vitrectomy was done. And a day after vitrectomy, there were multiple new retinal infiltrates seen inferiorly as seen in the OCT and the fundus photo. And then eventually the results came back positive for Candida. And during this time, patient was shifted to oral voriconazole and intravitreal, as well as steroids was eventually ceased. By day 7, after that surgery, there was subretinal abscess, vitrectomy was again done, voriconazole resistance was noted, and then we shifted the patient to amphotericin B. There were several issues like the CKD, the nephrotoxicity from the amphotericin B, severe pain during the injection, and so these were the issues which became a problem in delivering care for this patient. And eventually, inflammation resolved around 6 months since the first visit and with a lost eye. So learning points from this case includes early and frequent monitoring is very essential, particularly when treatments are not effective. When social and systemic barriers prevent optimal care, close follow-up and also alternative approaches are very crucial. Promptly discontinue steroids when fungal etiology is still suspected. And multidisciplinary collaboration is very critical, especially in complicated or resistant cases. And always choose life oversight.
Okay.
Yeah. So in summary, infectious uveitis requires structured monitoring, timely treatment adjustments, and collaboration with specialists. Recognizing early warning signs and personalizing patient care allows us to effectively manage this condition and improve outcomes. Thank you for listening.
So, on the want of time, this will go to the next talk, and at the end of the talks, we will take the questions. So, it gives me immense pleasure to invite my co-chair, Dr. Rupesh Agarwal from Singapore. He will be talking on holistic patient management. Rupesh.
So, thank you, Dr. Vishwas. Thank you, Professor Harvey, and thank you, Professor Kwan, for having me here and speak to you a little bit differently than the regular talks. And in view of, we've spoken about the infections and non-infective etiology, let's move on and speak a little differently about holistic management for a patient with uveitis. Can I move the slides? No. Okay. So just to give you a little background about the uveitis, some of the numbers. So the numbers which we know, it forms a reasonably sizable number of patients coming to the clinic, but a big number of what result into the visual morbidity. So what is not been highlighted is the number of morbidity or the amount of morbidity which it can leads to. So these are some of the numbers which comes up. 1 in 3 patients suffer visual impairment, 10 to 15% of the blindness in developed countries, significantly developed ocular complications, and a lot of it in developing countries. And there are many different reasons, many different factors which we can go into that. And that's where it called for action about some of the holistic management for uveitis, but we need to understand the impact or the burden of the uveitis and the challenge which the uveitis is causing. Now this picture is from the ChatGPT Delhi. But to highlight on the picture on the left for a very beautiful smiling person, and when you get a uveitis, you can get kind of a horror picture, and this can be a sight-threatening, life-threatening, and has systemic and vision-related complications affecting the quality of life and psychosocial well-being, just not of the patient but of the family and the community around. So it is not good to be a patient with the uveitis because you just not get affected but your entire family. A beautiful article by James Rosenbaum and the colleagues where he paint the picture of the future of uveitis treatment, where you put the patient on a slit lamp and then you assess based on what is going to be the future in 2020, 2033. You probably see instead of cells, maybe you see some cytokines there, or you, instead of imaging, you start seeing some biomarker, and that warrants you, okay, give me steroid, give me anti-syphilis treatment, give me tubercular treatment, give me whatever specific treatment. So maybe we will be heading towards, but as of now, what it stands, and we all agree with me, that the standard of care 20 years before was oral steroid when I was doing fellowship with Dr. Biswas. Standard of care today is oral steroid when I am having fellows with me, and I don't know in another 10 years, 20 years, the standard of care will change. So we are still talking about, and which we all know that it's not a very specific, but it's a broader treatment, and it probably will have challenges in terms of when to give, when not to give, and what are the side effects of it. So what I put together is into this is 4 segments of this talk. One is about the management of eye-related uveitis attacks and the medications and the side effects. But the other 3 aspects is the future of treatment of uveitis possible and preventing recurrences, and something related to psychological support to improve quality of life. And I think no one else better than Dr. Sangwan is one of those big supporter of some of this thing, and I think he will support some of the concept which I'm going to put together. So this one I'm not going to spend a lot of time because we all do that, but I'm just going to suggest that we all work towards preservation of the function in terms of visual acuity and whatever the functions which are talking related to eye, control the activity of inflammation, prevent recurrences. Sometimes we give prophylactic treatment, but typically I don't believe in prophylactic treatment where patient want a drop of steroid to be kept along with them whenever they travel. I personally don't believe, but I do know the colleagues who do that, and but again it's a lot of variations in our treatment, and of course to prevent complications. So when you see a patient, for glaucoma we have our end IOP and some of those things there. Here again we should have a clear objective that it might change. So one of the important thing is that the objectives might change with the steps. So it is a very dynamically evolving objectives, and it's a important thing which we need to take into consideration. So as Professor Kwan said to one of the questions there, what you think today based on a particular image, things might change based on a certain image. So most of the things this way you can escape if you make some blunder that you say patient, oh maybe I thought about starting steroid, but now I don't think you should need steroid. Maybe I thought about giving antitubercular therapy, I don't think you need it. Other way you can change because things change quite significantly in uveitis and all. So it's very much like a field of dermatology and some of the rheumatology and immunology. Once again, I'm not getting into the details of it about the diagnosis and epidemiology, but I just want to highlight it is important that you know where you practice so that you understand whether you are in Singapore or in UK or in US. It is good for you to know about your patient, where it is coming from. So demographic is very important. Understanding a good diagnosis is crucial. So this is a beautiful article in AIOIS. You can read through this, and once again Baram Badogi writes some of these amazing articles, and this is really given a very step-ladder approach. How do you come to the diagnosis? There can be some variations here and there based on the individual practice, but this gives you a scope into how you can come up with a step-ladder approach. Again, not getting into the details. When it comes to the management, we have spoken about different ways you can manage a patient, but again a step-ladder approach is identify uveitis, grade of inflammation, severity of uveitis if possible, define a clear objective. So if you can go back with this lesson that once you see a patient, define a clear objective, start with treatment, and as been rightly said, rule out infectious cause. But I wanted to highlight there, while you are ruling out infectious cause, it can take another 2-3 days. What are you going to do in those 2-3 days? You are going to leave the patient as it is. Are you going to start topical steroid? Are you going to give systemic steroid? Are you going to pulse the patient? A lot of things will be taken into consideration. So we are not getting into details again. Again, topical mydriatic agent for symptomatic relief. Lots of people love to give NSAIDs, but again be careful. Thinking about systemic steroid, not to think twice, thrice before you give systemic steroids. Again, plan a treatment strategy about it. Not getting into the steroid sparing biological therapy because I wanted to spend some time on the future. Again, the infective uveitis we've spoken. So where do I see, how do we change our practice? And I personally is a strong believer of some of this thing, not that I am following this. So these are the things which probably will be hitting our deck in near future. One is about the microbiome, which we really do not understand. So when I say about microbiome, it is about the food we intake, about the diet we consume, and I think the fermentable diet, I think it is coming up in a big way. People are very health conscious, whether it is for calories, weight reduction, a lot of different reasons. But I think one of the things which will be coming up soon to our clinic is about the adjuvant therapy with the microbiome. So there might be, already there are many companies who are doing your microbiome profile, but eventually there will be a company who will be giving you microbiome supplement for preventing attacks of uveitis or managing attack of uveitis. So you will see probably a uveitis specialist in another 5-10 years, 20 years, who will give you one of those doses of microbiome which can help you. So small conflict of interest. We've been working on some of these things, but I think there are a lot of people working on this concept, but it will take long time. It's not that easy, but I think something evolving. The second concept which I wanted to introduce and the term which I wanted to introduce is the concept of salutogenesis. Now, what do you mean by salutogenesis? So salutogenesis is the reversal of pathogenesis. Pathogenesis is healthy body to unhealthy body. But if you want to change the way uveitis patient can behave, you have to convert unhealthy body to an healthy body. So that is what a concept of salutogenesis is there, and something which I got to know from, not this Aaron, a friend of mine in University of Washington, Seattle, Aaron Lee. So he got a grant, he and Cecilia Lee, they got a grant, and Aaron was speaking at a symposium at SNEC. There I heard the first time, then I went on Google and then read this book by Aaron Antomsky, and really impressive book, and something which they define. Then I thought immediately, why should not I do this concept in uveitis? So I started looking into it, and then we published a paper related to that. So there are three important things in salutogenesis: comprehensibility, manageability, meaningfulness. So I'll spend a little bit of time on this thing. So this is a Greek word again, salutogenesis versus the pathogenesis. So what it covers is your well-being. So here in this complex picture is about how you're able to cope up, about how you're able to understand, about how you're able to cope up with the stress. This is what it is trying to say. So again, there can be n number of stress which can be affecting you: psychological stress, professional stress, physical trauma, interpersonal argument, environmental, multiple things. But it's all about your body, how it is able to cope up with some of those things, and which is going to convert your state of stress and how you manage either into the state of disease or into the state of health. So the implications of this concept is about enhanced patient understanding and engagement, wherein you spend time with this patient, making them understand about this disease, understanding patient's sense of coherence and sense of understanding about their own, involving patient in the decision making, which sometimes we lack. I think some of us will agree, we lack making patient as a part of journey, emphasizing about the preventive measure if we know, and promoting emotional well-being. So very quickly about SOC, which we spoke about, sense of coherence. So there are three important components and which we all need to understand, and this is something which we don't spend that much of time, and I request the AIOIS to probably have some couple of sessions on this from the next future thing if it's possible. So the first component of SOC or sense of coherence is comprehensibility, which allows you to understand and interpret the information which you are receiving. A patient can receive information from external internal sources and interpret the information in a meaningful way. Then when he receives the information, how does he manage the information? So degree to which a patient is aware and knows how to utilize the resources around and how to utilize and the challenges around. Third is meaningfulness. So how motivated a patient is to take those changes. So I understand I am obese, I have obesity, but how motivated I am to reduce my weight, how motivated I am not to eat too much of food and all, and how motivated I am supposed to run a marathon or spend some time on that. So that is again about those meaningfulness which we can apply. And there are many different things which can come around it, but in view of time, we're not going to get, but I just want to leave you with a concept of promotion of a sense of well-being amongst that. And that gives us this future perspective where the holistic concept will involve personalized medicine and targeted intervention, which we are doing to a certain extent. However, what we need to do is integration of this mind-body interventions at some stage. We do it in a small way in our clinic, but we probably need to do it for every single thing, for maybe a uveitis care nurse, a uveitis support group, something like that probably will allow us to do that. And then interventions and health promotions. Sorry, this one was coming on the way. I did not realize. Okay, leveraging technology for health monitoring and education. So we talk about telemedicine. Can we have some of those technology to deliver care and information back to the patient? And then of course we need to do some of the longitudinal study. So with this concept and with this overview, I want to kind of leave you with the future of uveitis and the holistic care. Thank you very much for your patience.
Thank you very much, Professor Rupesh. Yes, this is, I think, a very important and interesting topic. In a busy uveitis clinic, we usually don't have time to sit down and manage these patients. So in your clinic, what do you do to introduce patients to a more holistic form of care for uveitis?
So very good question, and I do this practice. What I do is when I see a new patient, I know that is a complex patient. So usually I ask them to come either in a lunchtime slot or after clinic slot, because there's a busy clinic and you can't spend time, maybe 15-20 minutes. So I book them separately, let's say 5 p.m., 6 p.m. or something around, or on the Saturday, and spend a lot of time. I tell them to get more family members, spend time, first of all, explaining them about uveitis. So I take out a paper, draw the diagram, make them sure that every single member in the family understand. And then I do give all the related information, some websites and some of those things to read about, and all the medications which are giving. So one is about educating them, which I spend time, and then a constant dialogue every time we come, and we also talk a little bit about their professional life, their personal life, and see how that is affecting it. And sometimes some patients get emotional, they start crying, and just now in the lunchtime I had a crying patient, she called, and some of the patients also take mobile number for those things. You have to kind of come up and see whether you can go, you have to just go little extra mile, I say. I just say that I just try to make a conscious attempt to go an extra mile to help this. Otherwise, I'm not telling them go and do meditation, go and do yoga and all. I just ask them to live a normal life. If they are sleeping less, sleep properly, make a regular lifestyle. So those things I spend a little bit of time in my clinic. Yeah, yoga is, huh? Yoga is normal life. Yeah, yoga is normal life. For you, for not for people like me. Yeah, thank you.
Yeah, thank you. So, interest of time, we'll move on to the next speaker, but we'll save questions for the end. So, I'd like to introduce now our next speaker from the Byers Eye Institute in Stanford, Dr. Jia Horung Hong, who will speak on advanced imaging techniques.
Thank you for the kind introduction. This is my financial disclosure. Retinal imaging are very important in management of uveitis, especially posterior uveitis. Oops. Sorry, how can I do this? So we use color fundus photography for diagnosis and management. And our team has proved that the wide field retinal imaging can be very important in the management of the non-infectious posterior uveitis. And recently, our team has further proved that the use of baseline fluorescein angiography can actually expand our knowledge about the activity of the disease. Of course, we also use OCT and OCTA for the uveitis. And today, I would like to focus more on adaptive optics AO imaging and also the retinal metabolic imaging, also known as OcuMed beacon. First, let's take a look at the adaptive optic imaging. This system is a high-fidelity focusing system that has been widely used in astronomy and vision science. This system is used to correct the high-order aberrations of imperfect optic systems. As you can see on the right-hand side, the point spread function can be normalized into a dot after the turn-on of the AO system. This is the look of the machines. So using this system, we are able to visualize the retina in the cellular resolution. It has been used to evaluate in several retinal diseases, such as white dot syndrome, diabetic retinopathy, retinal vasculitis, BKH, autoimmune retinopathy, etc. Here are some examples. AO can differentiate the activity between active peak and inactive peak by showing active lesions have focal hypointensity lesion, while hill lesions have circumferential hypointense halo. In microperimetry guided AO analysis in white dot syndrome, we are able to show that there are positive correlation between the retinal sensitivity and photoreceptor density in white dot syndrome. Furthermore, we can also use AO system to visualize the retinal sheathing, vascular sheathing in retinal vasculitis. For monitoring non-neoplastic autoimmune retinopathy, AO system shows that the cone density was reduced in all AIR patients. In VKH patients, AO systems are able to demonstrate that there are transient photoreceptor abnormalities. If we quantify the photoreceptor density, we could show that the mean cone densities at the follow-up are significantly increased compared to those at baseline. However, those with disease patients cannot reach to the normal level of a healthy patient after 12 months of follow-up. Now let's take a look at the second modality, the retinal metabolic imaging. This system is used to visualize the mitochondria function. Why we need to monitor mitochondria? There are evidence showing that mitochondrial dysfunction has been prevalent in various retinal diseases. And a major cause of the mitochondrial dysfunction is oxidative stress. Mitochondria exists in the ellipsoid zone and RPE. So diabetic retinopathy, AMD, and glaucoma all will lead to increase of ROS and leads to oxidative stress, and through the inflammatory signaling upregulation, there will be mitochondrial dysfunction. And this is where Ocumet Beacon can detect. So this is the stage where the disease is still reversible. And because one step later, there will be cellular death and disease. Therefore, this machine is developed trying to detect the disease earlier than irreversible stage. And how can it do that? This machine is used to detect the flavoprotein fluorescence, FPF. Flavoproteins are a class of proteins that are associated with electron transport chain in mitochondria. If there is increased FPF, that means there's a shift toward oxidation which occurs under oxidative stress. So this is a diagram showing that oxidative stress leads to the increase in fluorescence. Therefore, this machine can detect the flavoprotein autofluorescence and in a rapid and non-invasive imaging way. It also can provide cellular level metabolic insights. So on the upper panel is the normal FAF, and the lower panel is the imaging that Ocumet Beacon can provide after proper analysis. So in clinical setting, they quantify the FPF into two scores. One is the average intensity, the FPF score. The other one is the curve width, also the heterogeneity. So normally, the level of the FPF score should be lower than 50. It has been used to evaluate several retinal diseases, and including IRDs. For example, in Stargardt disease, it shows that abnormal FPF score correlates with those flecks. And those areas with RPE loss, there are also loss of the FPF signals. And interestingly, the FPF elevation has been demonstrated in primary open-angle glaucoma. Therefore, these diseases are related to inflammation and related to the increased FPF score. And how about uveitis, which is a direct relationship with the inflammation? In animal models, there are evidence showing that mitochondria-specific oxidative stress are related in the pathogenesis of uveitis. Therefore, this is the area where our group is now actively focusing on because this is a quite novel technique. With the help with my colleague, Dr. Rajabi, let's take a look at the three examples. This is a 57-year-old female with posterior uveitis, positive A29, and the management now is adalimumab 40 mg every week and methotrexate. On the ICGA, we could see typical findings of birdshot chorioretinopathy. And let's take a look at the FPF score. So there are elevations of FPF score not only in the macula, but also in the optic nerve. This is the second case. 66-year-old female with birdshot chorioretinopathy using adalimumab 40 mg every 2 weeks. On ICGA, we can show that we know that there are less dots compared to the previous case. However, as we look at the metabolic profiles, we could see that the FPF score elevated even more compared to the previous case. As we could see that the optic nerve in the central panels, there are highly elevated FPF signals. Therefore, we can use this result as a potential to adjust our treatment. Probably, we will need to increase the treatment dosage or increase the frequency because there are still metabolic dysfunction. And the last case is a 56-year-old female. The diagnosis is retinal vasculitis with positive B51. Fluorescein angiography shows that diffuse retinal vascular leakage and also the involvement of the optic nerve. And as expected in the lower panel, we could see that there are a marked elevation of the LPF score, not only in the macula, but also in the optic nerve. We can see the red color that shows that the increase of LPF score, therefore indicating the whole retina now is under metabolic stress. In conclusion, today let's talk about, we have talked about the AO imaging. This system provided high resolution and fast images at the cellular level of the posterior segments. And the second imaging modality is augmented beacon. So it can detect the mitochondria function, and it can potentially provide cellular level metabolic insights. I really hope this talk can provide you with the insight of how the research is now going on. With that, I would like to thank my mentor, Dr. Kwandong Wen, Dr. Argawo, and Dr. Rajabi, and the whole team. And we would like to invite everybody to join us in Rio de Janeiro for AIOIS meeting. Thank you very much.
Thank you very much. We'd like to, for the want of time, we would go to the next talk. And it's my pleasure to invite my friend and great uveitis specialist, Dr. Birendra Sangwan, who is from Shroff's Charity Eye Hospital, New Delhi. He will be talking on a topic similar to Dr. Rupesh Agrawala's talk, patient education and communication. Dr. Sangwan, please.
Thank you very much, JB, and just give me a minute while this is being set up.
So while waiting, I'd like to ask Rupesh, were you able to set up a uveitis support group in your practice? And how did you do that?
No. I'm still waiting, not yet. So I hope I need to learn maybe, but haven't been able to do that. But that's something, a wish list, in my wish list. Thank you.
All right, I'm back in business. Thank you very much. And communication, patient communication. I think it's as important as your diagnosis and treatment. And I'll try to make a few points with the examples. Who can have interest in patient communication? I have no commercial interest. You didn't get the joke, right? Sorry. You know, when somebody is diagnosed with uveitis, the patient is scared, and most of the physicians are scared. So they transmit their fear to each other, and that fear gets amplified, and the communication does not happen. Sometimes the the diagnosis uveitis carries such a negative connotation that will drive patients much more crazy, and they start looking at the internet. Some I hear from patients that doctors told me cataract surgery in uveitis is dangerous. It's very poor prognosis, so you should not get it done. Use of systemic steroids and immunosuppressives is very risky and dangerous. Sometimes patient comes and they tell that doctor did not tell you, maybe you suffer from cancer. These are anti-cancer medicines he is giving you. Maybe he didn't want to discuss with you. So they start consulting neighbors who are not physicians. So my request and advice is that if you used to take care of these patients, we must learn to understand the pathogenesis and treatment of the particularly uveitic entity, so that you can communicate better. Once we understand better, we can communicate better. So I'll give you this example of a patient who I managed in early 2001 following pterygium surgery. He developed this kind of presentation. So when you look at this, immediately you will get scared. Oh, my God, there is a hole in the eye. And then panic is, oh, I need to do a scleral patch graft, which I think is not a good idea. Because if you put a graft in a patient who is having active inflammation, the graft will also melt. So therefore, it's very important that you treat it immunologically or with immunomodulation, and then only do something like in this patient, he received systemic cyclophosphamide, systemic steroid, IV methylprednisolone, and then he underwent a scleral patch graft. And then to keeping the patient's morale, you need to be very positive and empathic. So this patient did well with all this treatment and subsequently underwent a cataract surgery after 1 year, and he did very well. 20/25 vision in that eye, not a bad idea, not a bad outcome at all. This is a girl who had was diagnosed as VKC at multiple locations, multiple places, and somebody has given a supratarsal steroid injection, and she has developed tarsal necrosis. And she was referred to me in LVP, and she has consulted 5 different doctors. What I saw was there was some kind of a PUK, there was a mass, there was a AC reaction, there was fine KPs. I did not understand what it was, but I have not seen any tarsal necrosis in a patient with VKC. So I said it's very atypical. So I took a conjunctival biopsy, AC tap for PCR, and to my surprise, she was diagnosed to have conjunctival tuberculosis. So here, the diagnosis and the treatment and the communication, they are all equally important. And this girl received full dose ATT and became all right. Now, this is one of my very early experience in LVP in 98, 99. Patient came with a PUK type of a picture and following cataract surgery, and he underwent annular patch graft. I was very new faculty, so I suggested my senior that maybe we should give immunomodulation. He said, no, not required, maybe this is very mild, it will be fine. And after a few weeks, this patient was from Calcutta. After this, the patient comes like this. And now, if you do conjunctival resection, TABCL, IV cyclophosphamide, Visolon, it's useless, because we have to understand the specificity of the immune response and need for immunomodulation. So by then we have lost the game, and the patient's this eye is lost, practically lost. I mean, because there is a extensive melt of the lamellar patch graft we did, and then the rest of the cornea also infiltrated. This is a patient who was referred from Ahmedabad, and please watch this video. Based on the reports and the clinical picture and the clinical examination, I felt this is a typical case of sarcoidosis, and I offered her treatment, but she came with a specific question. She said, I have been told by multiple doctors this is eye cancer in the iris, so I want to be sure. So now what is that you want to do? So you have to communicate, you have to convince, but she says, doctor, I want a proof that it is not a cancer. So we did a knowing fully well that it is not justified, but because the patient's conviction was very strong, so she underwent this iris biopsy, and that proved what our clinical diagnosis was. So sometimes you may have to listen to patient what is important to them. I could have told her that no, there is no point doing all that. She would go somewhere else and get it done, because that is what is bothering her. So it's important to address the patient, not just the eye problem. This is a doctor, medical student, who was referred for posterior uveitis, which has been fully investigated, on systemic steroid, used regional steroids also, and referred for persistent floaters. Now, when I see this patient, it's a typical fuchs citrochromic iridocyclitis, and floaters are almost always there, will be there, even if you do cataract surgery or if you do a vitrectomy. So they are not going to go away. So therefore, here understanding the natural history of the disease and what is the reported literature say, and then conveying that appropriately to patient is very important. So in my view here, there is no role of clinical, all the investigations. Basically, you need to tell that this is how this disease behaves. Floaters, how you deal with the floaters is a different thing, and then you can teach them coping mechanisms of how you deal with the floaters. I tell my patients that floaters are like an irritating neighbor. Come whatever you do, they'll keep coming back. So don't pay attention. And you know, they'll just keep coming and bothering you. The more attention you pay, the more they bother you. And they go in the opposite direction. So if you move on the left side, they go right side. Then you change this. So I said it's going to happen. So if you start playing that game, you go crazy. So once we have investigated fully posterior segment, we've done everything, and we are convinced that this is what it is. Therefore, you don't need to do much investigation. Yes, if there is a cataract, deal with it. If there is a glaucoma, deal with it. Generally, these patients don't need systemic treatment, and vitrectomies have not helped in relieving the floaters. So therefore, it's very important to have clarity. Cataract. Now notice at the whatever the pupil part of the pupil is reacting. So what does it tell you as a clinician? It tells you that if you do a cataract surgery, the prognosis cannot be very bad. Even if the patient has a fastened pupil, even if he had recurrent uveitis, so you can raise the hope that okay, we will do cataract surgery, and if you are a good cataract surgeon, you can obtain very good outcome. So cataract surgery, to my mind, in patients with uveitis is not a problem at all. Generally, if it's well controlled uveitis, you don't get you can get good outcomes. Available treatment options, we have various speakers talked about it, but primarily systemic steroids, immunomodulators and biologics is the key. And why this is the key? Because despite all these kind of treatment, we have a serious inflammation which can affect the outcome and cause morbidity. And these are some of the complications and sequelae of ocular inflammation. So in summary, the right way of communication to the patient is key, and right way of communication is understanding yourself, the disease, and not only disease, yourself also. You should know how you react. If you say perforation, then if you get scared, obviously your patient will get scared. In some of the uveitic diseases, steroids alone may not be sufficient, and immunomodulation and biologics are important adjuvants. Thank you very much.
Thank you, Dr. Sangwan. Always great to listen to you. So, as you know that we are already time up of 2:45 p.m. before we hand over, and we still have one talk which we haven't completed. So, what I am going to offer to you is to come again for the part 2. So, whether you call it as a Bahubali return or uveitis return, we'll do it after 48 hours exactly from now in the same hall for Professor Pei-Jing Yang talk. And it's again the session number 2, living with uveitis, patient's perspective and managing ocular inflammation, and where we'll answer your question, gentlemen, and also play the video by Professor Pei-Jing Yang. But just that next session is starting at 3. We still have some time. So I invite all the panelists, the speakers in front, not just for the group photo, but also to take up the questions from the audience. So if the panelists can come in front, and we can have. So we'll do now. You come in front also. Okay. The questions. Who are the people? Who probably can we have questions from the floor or comments from the floor? Yeah, please. So while people are setting it up, just wanted to kind of quickly ask Dr. Sangwan about his talk and his experience about the management. How do you kind of like really do it in your practice about telling the patient, particularly the bad news of uveitis and the crying patient, how do you manage them?
Well, I think over the years, what I understand, Rupesh, is patient will cry if you, the way you share the information. See, many of you or many of the clinicians think that giving more time is, very good. I think it is what matters is how you connect with the patient, how you share the information, and what is your body language when you're talking. If you don't have conviction, what you are saying, what you are doing, your patient will never be convinced, whether they are educated, they are not educated. So it's very important that whatever you are saying, you have a conviction, and this is the same treatment and same thing you will tell to your family members. That is the bottom line. If you are working with that conviction, then your communication will be very good and it will be conveyed to the patient also.
Thanks, Surender. I have a question for Professor Mahendradas and maybe any other speakers in the audience. What are your experiences with the suprachoroidal steroid injections? Do they work as well as systemic or intravitreal injections?
We just started using it. We found to be effective in posterior uveitis, and macular edema part it takes care. And it's too preliminary to share the results, but it is effective in posterior uveitis.
And where are you sourcing the needle? Where do you get their needle?
This is supplied and done by my retina colleagues, locally made one.
So I can't miss the advantage of having Professor Kwan here. So while you are here, just wanted to check with you about the clinical trials and FDA. Are they looking into the patient-reported outcome measures, or when? No, he's going through the mic. I hope you're not going out. Long way. So when you design the clinical trials with the visual acuity or cystoid macular edema as the outcome measure, is there any role of quality of life or patient-reported outcome measures in that taken into consideration by the clinical trialist or the FDA?
Yes, so Rupesh, thank you. So first, the product currently a suprachoroidal delivery of 0.1 ml, 4 milligram of triamcinolone acetonide for the indication of uveitic macular edema is the product Kozai here. The clinical trial that put it to approval is called the Peachtree study in that aspect. So Rupesh asked the question of that. So yes, indeed, the primary endpoint for that was the visual acuity was the primary endpoint, but at the same time using the central subfield thickness. To your point, there was also asking the question of whether or not how the patient feel about it compared to, for example, taking oral prednisone and other things. And there was a positive correlation for that aspect from there. So definitely patients have tolerated better than taking systemic med. Now, if you were to ask the question, what about suprachoroidal versus intravitreal, then patient would probably tell you, at least from the study, that they notice that with the suprachoroidal, they can feel more pressure of that type of thing because you actually spread it out the suprachoroidal space, which is a potential space. So therefore, when you injected that, even though you spread it slowly, they will feel the pressure. So that in terms of that goal. But certainly, I'm very certainly encouraged by the fact that the colleague from India and today heard from a colleague from Vietnam as well to develop your own needle from this aspect. That's one have been the limiting factor of that. And so right now, I believe that you go with a perpendicular needle that go to directly to the suprachoroidal. In the US, we're also looking at other way to deliver suprachoroidal too. So instead of going directly perpendicular to the surface, the later approach right now is to go actually tangential so that you really can get to that area. You basically dissect our space and you deliver the catheter there. That. So there's other way to go, but suprachoroidal is certainly here to stay because in addition to triamcinolone, if you follow the clinical trial, several of the vector therapy where you deliver a viral vector to contain, let's say, aflibercept or, for example, faricimab and other things are being developed as well, and also for some of the gene therapy also deliver suprachoroidal.
Okay, so with that final comment from Professor Kwan, is there no other questions? We'll conclude this session and we'd like to see you again after 2 days in the same room to continue with whatever we discussed. And if I can invite the speakers in front for a group photo and including Professor Kwan as for the photo, not just to take the photo. Yeah, please. And thank you once again for giving your time to listen to Uveitis. And for a change, it was a record audience there. Thank you very much for your patient listening. Thank you. Very good, very nice.
Wish you had more time.